What makes you excited at the AHA this year?
Well, look, there's a buzz in the air. We're sitting here together with your poster, your popular poster, and seeing so many people talking about science, interacting, seeing old friends, just even exchanging, information about each other in ways that they haven't been able to do before.
Just so excited to be at the AHA 2022. The place is packed. There's so much excitement all around the clinical trials, case studies, and just networking with our colleagues. It's wonderful to be back together again.
What are the thrombosis-related studies or presentations you're looking forward to at the AHA?
I'd like to see where we're at currently with chronic pulmonary thromboembolic disease and pulmonary hypertension. I think that that's an area where we still have a lot to learn and we have a lot of progress that we can make. So I'm really looking forward to some of those sessions.
I just presented the top-line results of the IMRPOVE-DD trial, which shows that a universal electronic health record embedded BT risk score using clinical decision support, namely IMRPOVE-DD is the score, not just changes behavior, which is increases rates of appropriate thromboprophylaxis, but also leads to a reduction in heart outcomes, namely thromboembolism in hospitalized medically ill patients. So that's quite exciting.
Do you think the design that you had for this trial could be implemented similarly in other contexts for thrombotic diseases to be applied to improve appropriateness of treatment, thereby patient outcomes?
Yes, excellent question. The key is to have an EHR-based tool that can be adopted into any EHR environment. So for doing that, we had Smart on Fire-like platform, as I showed, which can be plug and play into any EHR. And the second thing is how to use this adaptation. So what we did is apply the tool not just at admission, but in a brand new workflow at discharge as well. So applying the tool both at admission for VT risk stratification, but also at discharge, was able to not just reduce in-hospital rates of thrombosis, but post-discharge rates of thrombosis. And let's not forget, in North America, most of thrombotic events in the hospitalized medically ill population is occurring in the post-discharge period. So if you don't change that, you're not going to move the needle in terms of the 30-day rates of thrombosis.
I think the take-home message is that in the largest trial focused on non-hospitalized medical patients with COVID-19, we were able to show no significant difference in broad endpoint of thrombosis, hospitalization, and mortality, providing more confidence to the previous studies that showed that probably broadly applying thromboprophylaxis to patients with COVID-19 who aren't hospitalized is unnecessary. And I think that we provide more confidence based on a larger sample size to say that we can safely withhold this therapy in most patients. Now, there may be some patients with very high risk of thrombosis where it might make sense, but at least broadly speaking, I think we have answered the question at hand more definitively now.
That's incredibly helpful. In addition to the content of the trial, another very interesting feature was that you were using electronic tools for patient recruitment, and it seems like you masterfully overcame many of the traditional obstacles in being inclusive to many of the subgroups that are traditionally excluded from other randomized trials or underrepresented. Can you comment on that a little bit as well?
Well, I think that really related to two things. Like I mentioned in the talk, or the questions afterwards, we had incredible response from our community around Boston to participate in this COVID-19 focused study. I think that helped us. I think that the electronic health record tools that we use to identify the big denominator of patients with new diagnosis of COVID-19 enabled us to draw across different communities in the Boston area. And I think that just the way our team rallied around and wanted to include a diverse population, we put in the extra effort to make sure that we were getting women and underrepresented minorities and giving them the opportunity to participate in research.
What are the interesting and exciting studies in the field of thrombosis that you are looking forward to at the AHA?
Well, actually, and this is a little bit biased, but two of the most interesting ones are studies that we're actually presenting. One is the Bright 4 trial, which is a large-scale 6,016 patient randomized trial in patients with ST segment elevation, myocardial infarction undergoing primary PCI, with anticoagulation with either bivalirudin with a 2 to 4 hour post-PCI high-dose infusion versus heparin monotherapy. with glycoprotein 2b3 inhibitors reserved for procedural thrombotic complications. And almost all the patients in the trial underwent radial access. And so this is answering the major question of taking the two best regimens that have bivalirudin with a post-PCI high-dose infusion, heparin monotherapy, that have never been compared head-to-head in an adequately powered randomized trial with all of the confounders removed to really be able to isolate the effects of those two therapies. And prior meta-analysis has suggested that those are the two best regimens and that bivalirudin may have an advantage, but of course you need a randomized trial to prove that. And what was actually shown in BRIGHT 4 is that bivalirudin treatment in this population reduced all-cause death, reduced major BARC types 3 to 5 bleeding, and in addition to not increasing stent thrombosis, the 2 to 4 hour post-PCI high-dose infusion was associated with a reduction in stent thrombosis from 1.1% in heparin monotherapy treated patients, a little higher than usual without the 2b3 inhibitor, to 0.4% with the bivalirudin regimen at 30 days. No significant differences in stroke, ischemic TVR, or reinfarction, and overall MACE borderline reduced by bivalirudin and net adverse clinical events substantially reduced. And almost all the prevention in major bleeding came from non-access sites because since radial artery intervention was used in 93% of patients, there was almost no access site bleeding. So this is really a transformational trial in my mind, and it really demonstrates that bivalirudin, which is now generic and now not much different in price than heparin, should be standard of care in patients with STEMI undergoing primary PCI with radial artery access. The other trial, which has been very interesting, was a study that we put together with Behnood Bikdeli, and that was a patient-level meta-analysis of all of the large-scale randomized trials in non-ST segment elevation myocardial infarction that randomized bivalirudin versus heparin, with or without different sorts of regimens. And there was no overall difference in major ischemic outcomes or survival, but there was a major bleeding benefit and therefore improvement in net adverse clinical events with bivalirudin, suggesting that also in patients with non-STEMI undergoing PCI management, bivalirudin is a superior treatment regimen, which again is not much different in price compared to heparin right now. So hopefully these studies will be accepted well and adopted universally across cath labs.
Wow, that is incredible. Thank you so much, Dr. Stone, as always. Much appreciated.
My pleasure.